A warm welcome. I welcome you to this session where we'll be discussing about congenital heart disease. Give me a minute, I hide this. Okay. We'll be discussing congenital heart disease. This is the second part. I've done a very nice video in part one. Please watch it. In this session, we'll be discussing cyanotic shunt anomalies, also known as the right to left shunt anomalies. And there are quite a number, but today we discuss just two: the transposition of the great arteries and tetralogy of Fallot. This tetralogy of Fallot is very important. You need to understand it. Then in each we look at the morphology and clinical features. As always, my name is Boris Munyiri, and I'm the Daktari. Now, cyanotic shunt anomalies. Let's define what shunt is. Simply, it's an abnormal communication between heart chambers or blood vessels. And the communication is bilateral, okay, depending on the pressure relationships. It can be left to right shunt or right to left. When I say right, I mean blood is coming from the deoxygenated stream towards the oxygenated stream. The left to right, on the other hand, blood is coming from the oxygenated stream to the deoxygenated stream. Now, the right to left shunt anomalies are the ones which are associated with cyanosis. And cyanosis is simply a dusky blueness of the skin. And in the case of right to left shunt, we have an early cyanosis. Why early? Because in the left to right shunt anomalies, they have a late cyanosis. Why? Because eventually, due to increases in the pressure in the pulmonary circulation in the left to right shunt, there'll be a shunt reversal, the Eisenmenger syndrome. So at first they are acyanotic, but with the time, cyanosis presents. But in this case, early cyanosis is present. Okay. Now, the clinical consequences of this are usually severe. Okay. And some of the symptoms associated with the cyanosis will include clubbing of the tips of the fingers and the toes, what is known as hypertrophic osteoarthropathy. Okay. And how do you test for this hypertrophic osteoarthropathy? Maybe it's time I turned on my video and showed you that. Okay, so here I am. You use what is known as Schrathmos Windows test. And this is what you do. You take the patient's fingers and ask them to place their fingers in this position, if you can see. Okay, now, in my case, you can see there is a diamond-shaped slit between the two opposed fingers. That is known as the Schrathmos window. Now, when it is absent, due to this will present the Schrathmos window will be obliterated, okay? And that shows the patient has hypertrophic osteoarthropathy. And that will tell you there is a hypoxia, okay? And also, the Schrathmos windows test can be used in the diagnosis of bronchogenic carcinoma. Remember, one of the paraneoplastic syndrome of bronchogenic carcinoma was hypertrophic osteoarthropathy. Okay, maybe we will discuss that. Okay, so I hope you have understood how you can use the Schrathmos window to test for that. Okay, so also there is polycythemia. Why? Because when there is hypoxia due to this cyanosis, the kidney will be stimulated to produce erythropoietin, and the erythropoietin will stimulate the red cell precursors, the erythroblast, to produce more of the red blood cells. So there will be polycythemia, which will present with an attendant hyperviscosity. And so there is a paradoxical embolization in that an embolus, especially from the deep venous thrombosis, the thromboembolus from the deep venous thrombosis will migrate from the right side to the left and can cause systemic hypoxia. not hypoxia, rather ischemia, ischemic damage. Now, this is what I was saying, the Shathermoss Windows test. This is normal, the diamond shaped. You saw that in, so I'm normal. But when you have clubbing, the hypertrophic osteoarthropathy, it will present as this. This will indicate there is hypoxia, or it can be a paraneoplastic syndrome of bronchogenic carcinoma. So very important that. Now, tetralogy of FALLOT, I must know, because it is the most common cause of cyanotic congenital heart disease, okay? And it will present us the four cardinal features. That is why it is a four, okay? Four. You must understand this. One, stenosis of the right ventricular outflow tract. It can be a stenotic infundibulum, a stenotic valve, the pulmonary valve, or the pulmonary trunk itself. Also, there is right ventricular hypertrophy. Why? Because once this is stenosed, the right ventricle will be forced to pump blood against high pressures, and it will undergo hypertrophy, the concentric hypertrophy. Then there is a ventricular septal defect. Then there is an aorta that overrides the ventricular septal defect, so an overriding aorta. So those four I must know. And here is the image. You can see right ventricular hypertrophy. You can see a ventricular septal defect. And in this case, it would be a right to left, as the arrow shows. Then you can see here pulmonary stenosis, or the stenosis of the outflow tract of the right ventricle. Then you can see the overriding aorta, or the overriding aorta here. So those four I must know. Now, what causes this? Due to the anterosuperior displacement of the infundibular septum, okay, and during embryogenesis, and this will lead to abnormal septation between the pulmonary trunk and the aortic root. Now, the pulmonary trunk and the aortic root originate from the truncus arteriosus, which is the distal third of the bulbous cordis. They undergo septation if that septation is abnormal. The pulmonary trunk will become stenotic and the aorta will override. And this now will lead to the tetralogy of FALLOT. Now, how does it, morphology of the tetralogy of FALLOT? The heart is usually enlarged and boot-shaped due to right ventricular hypertrophy. I'll be showing you that. The proximal aorta is dilated, where the pulmonary trunk is usually hypoplastic. Okay, so it's hypoplastic. Then there is the left-sided cardiac chambers are of normal size, but the right ventricular wall is hypertrophied. Even at times, its thickness exceeds that of the left ventricle. Now, the ventricular septal defect is large and usually lies in the vicinity of the membranous portion of the interventricular septum. The interventricular septum has two parts, the membranous portion and the muscular portion. This VSD will be the membranous portion, where most of the VSDs are mainly in the membranous portion. Now, the aortic valve lies immediately above that defect, the VSD, and it is the major site of the egress of blood flow from both ventricles. So the overriding aorta will receive blood from both right and left ventricle. So blood from the right ventricle will now enter the aorta, and that will lead now to a right to left shunt, and that will now produce the cyanosis. Now, obstruction of the right ventricular outflow is most often due to the narrowing of the infundibulum. Remember, the infundibulum is the smooth outflow tract of the right ventricle. Its counterpart on the left is the aortic vestibule. And remember, the two smooth outflow tracts originated from your conus cordis, which is the middle third or bulbous cordis. Now, so in such case, obstruction of the infundibulum is known as a subpulmonic stenosis, but can also be caused, the obstruction can also be caused by pulmonary valve stenosis or a complete atresia of the valve and the proximal pulmonary arteries. Now, when you have pulmonary valve atresia or proximal pulmonary artery atresia, a persistent patent ductus arteriosus or dilated bronchial arteries become the only route for blood to reach the lungs. So there is need to maintain a patent patent ductus arteriosus if there is a complete atresia of pulmonary valve. So I told you the heart is usually enlarged and boot-shaped. So you can see this X-ray. You can see how it is shaped. It's shaped like that boot. I've drawn you a very nice one. So when you see this, just remember tetralogy of Fallot. Remember the 4 cardinal features. 1, overriding aorta. 2, pulmonary stenosis or stenosis of the right ventricular outflow tract, right ventricular hypertrophy, and the ventricular septal defect. Please remember those. Now, how does it present clinically? Now, the hemodynamic consequences of this tetralogy of Fallot include right to left shunting, decreased pulmonary blood flow. So if there is decreased pulmonary blood flow, I don't expect you to tell me there will be a pulmonary edema. So also there is increased aortic volumes. Why? The aorta is receiving blood from both right and left ventricle. So the aortic volumes will be elevated. So you can imagine how the pressure in the systemic arteries will be high. Now, some patients can survive into adult life depending on the severity of the obstruction of the pulmonary trunk or the right ventricular outflow tract. If it is mild, that obstruction, the condition will resemble an isolated ventricular septal defect. Why? If the obstruction is mild, the right ventricle won't be hypertrophied because it will not be doing work against any resistance. So in this case, the left ventricular pressures will be higher than those of the right. So blood now will be flowing from the left to the right. So there'll be a left to right shunt with no cyanosis. But with time, due to increased blood flow and pressures in the pulmonary circulation, it can go adaptive changes and increase the pressure in the pulmonary circulation. And hence, the right ventricle will undergo hypertrophy. And this can now lead to shunt reversal, the Eisenmenger syndrome. Now, also, as the child grows, the heart increases in size, but that orifice does not expand proportionately. And this will lead to progressive worsening of the stenosis. Now, the pulmonic outflow stenosis protects the pulmonary vasculature from pressure and volume overload. So pulmonary hypertension does not develop and right ventricular failure is rare in tetralogy of Fallot if the outflow is severe. Now, patients develop a typical sequelae of cyanotic heart disease, including the hypertrophic osteoarthropathy. And whenever I say this, please remember Charmot's Windows test. Polycythemia due to hypoxia with attendant hyperviscosity. There is also right to left shunting will increase the risk for infective endocarditis and systemic embolization, the paradoxical embolization, where an embolus from the venous side will enter the arterial side. Okay. Now, that was the tetralogy of Fallot. I need you to understand that. Now, transposition of the great arteries. When discussing this, I need you to remember the heart tube, which had an arterial end, which I'm drawing here, the arterial end. Okay. So let me draw 1, 2. Okay, I won't complete it, but I want you to remember this was the truncus arteriosus. This was the cornus cordis, and this was the proximal third of the bulbus cordis. All these 3 parts are parts of the bulbus cordis. Okay. Now, when one form of septation was known as, remember you had 4 types of septation, but I'll be discussing one here. Septation in the cornus and the truncus arteriosus, the cornotranco septation. And the outline of the septum is spiraling. Okay, it is spirals. And since due to that spiraling, the truncus arteriosus is one which gives rise to the roots of the great arteries. That is due to the spiraling of that septum. That explains why the aorta despite from originating from the left ventricle, it moves somewhat to the right, okay? And the pulmonary trunk, despite originating from the right ventricle, it moves somewhat to the left. So they cross each other, like crossing your two hands, your two arms. Let me show you that maybe in the video again. This is what I'm saying. Imagine, take your left hand. Okay, this is my left hand. This is my left, this is my right. So this, assume this is the aorta, and this, the right, is the pulmonary trunk. They cross each other like this, like Wakanda. Okay, Wakanda style. So in that, this is originating, the aorta originates from the left, but it takes a course. The course is towards the right, but the pulmonary trunk, on the other hand, originates from the right, but its course moves towards the left. So they cross each other like this. And this is due to that spiraling of the conotruncal septum. Okay, so I hope you have understood that. But failure of the spiraling, so non-spiraling conotruncal septation, will lead to the transposition of the great arteries. In that, now the pulmonary trunk will be originating from the left ventricle, and the aorta, in this case, will be originating from the right ventricle. So that is now the transposition of the great arteries. Now, but the atrioventricular connection is concordant in that the right atrium will drain to the right ventricle, the left atrium will drain into the left ventricle. Now, what is the functional outcome of this transposition? There will be a separation of the systemic and pulmonary circulation. And this condition is incompatible with postnatal life unless a shunt is present. And this shunt will allow delivery of oxygenated blood to the aorta. And that is why in a third of TGAs, they are accompanied by a VSD. And this VSD will allow oxygenated blood to reach the aorta. Now, it also presents with right ventricular hypertrophy because the chamber functions as a systemic ventricle. So it has to pump blood against high resistance. So it has to hypertrophy. It undergoes hypertrophy. The left ventricle, on the other hand, is hyperplastic because it pumps against the low resistance pulmonary circulation. Now, a patent foramen of veil or a patent ductus arteriosus allows oxygenated blood to reach the aorta. But these close, remember the ductus arteriosus will close after birth. But so such infants will require emergent surgical intervention within the first few days of life. Okay, so this is what I'm saying. You can see in this case, this is a transposition of the great arteries, TGA with a VSD. Okay, in this case, you can see the aorta here is receiving, it's the outflow tract of the right ventricle, and this should not be the case. Okay, so this VSD will allow oxygenated blood to enter, and so there is need to maintain the patency of this VSD. Okay, failure to do so will cause death, immediate death. It will be incompatible with postnatal life. Okay, in this case, you can see, so this is a TGA with no VSD, but with a patent, with a PDA, patent ductus arteriosus. This ductus arteriosus now functions as a shunt for oxygenated blood to now reach the aorta and go to the systemic circulation. Okay, so there will be need to maintain the patency of this. And how can you maintain the patency of the ductus arteriosus? By infusions of PGE. Okay, so you have a drug known as prostadil, which you can use to maintain the patency of that. Okay, so how does it present? Cyanosis, okay? And the prognosis of the TGA will depend, one, on magnitude of shunting, okay? Two, degree of tissue hypoxia. Three, the ability of the right ventricle to maintain systemic pressures. Without surgery, even with stable shunting, most infants of uncorrected transposition of great arteries die within the first month of life. So there is need for surgical intervention here. However, recently we have improved surgical techniques, and these permit definitive repair, and patients with TGA who undergo surgical intervention can now survive even into adulthood. So that is great news. So that was PGA and TOF. But that does not mean those are the only cyanotic shunt anomalies. We have others, such as tricuspid valve atresia. Okay. We also have the persistent truncus arteriosus. Remember, I told you truncus arteriosus has to go the conotruncal septation. Okay, if that does not happen, okay, due to failure of the neurocrest cells to migrate to form the truncal ridges and form the autopulmonary septum or the conotruncal septum, the truncus arteriosus will not undergo the septation, so it will be persistent. So there'll be a right to left shunt, a cyanosis will develop, and that failure, the persistent truncus arteriosus is mainly associated with maternal diabetes. We also have total total anomalous pulmonary venous connection. So those are some of the other cyanotic shunt anomalies, or the right to left shunt anomalies. So thank you for your attention, guys. And please follow for more of med content. Thank you very much.